my stuff's going to be very, very basic, but it's supposed to be a research update, but if we were going to do it properly, we'd probably be here for about a week. So I've just picked out some interesting stuff from recent studies, and at the end of it all, Erin and I will be able to do a question and answer session for you. So as Heather said just now, keep your questions to the end. Now I've just got to make sure this works properly. Let's see if that one does it. Yeah. Okay, so where are we at? Well, I think without doubt we all have to say our lives have been dominated this year by COVID, and there's a lot, if you've been attuned to what's going on, I'm sure you have around the world, there's a lot of emphasis on the so-called post-COVID syndrome, what they're calling long haulers, people who have had that very nasty illness, some of them not that ill, but they've remained very, very unwell, and it's certainly very much likened to chronic fatigue syndrome, ME, typical post-viral syndrome. There are some differences because a lot of the people who've had COVID have had a lot of chest trouble, breathing difficulties, heart problems, and so on. So there's evidence of more of an emphasis on those sort of symptoms, but many of the patients are certainly very, very similar to a lot of the patients I see with ME CFS. And I've actually had 3 post-COVID patients in the last few months. All of them, interestingly, young, and that means under 30, all female, and all had been very healthy people beforehand, but here they are almost bedbound, 5, 6, 7 months later. So I think what we have to say, this is going to lead to a greater awareness of ME internationally, and that's obviously very important for all of us. And there was a number of articles in the JAMA, which is the American Journal of Medical Association, about the whole post-COVID thing. They had a whole journal issue devoted to it, and they said that the post-COVID syndrome, or the long haulers, is really stumping the experts, and these are people, who are top of their field in the United States particularly. Interestingly, some of you may have heard of Mady Hornig. She is one of our leading researchers. She's particularly interested in the microbiome, which is all the bacteria in our gut, and she's a leading researcher in the USA, and she has actually been diagnosed with quite severe long-haul COVID, which is very, very sad, of course, but again, it's making a greater awareness of the illness because she is a person that's very well known. And so we all hope more money is going to get poured into research, and hopefully it'll come your way. Interestingly, very recently, within the last couple of weeks, the university here, which is Nancy Klimas's university, she's a leading CFS researcher in the US. She's visited New Zealand a couple of times, come down here, hasn't she, Heather, and spoken to the group. She's one of the leading researchers in the ME CFS world, and again, I've got to get this right, haven't I? There we are. You could just read that while I'm talking, but this is her comment. She's been awarded $4 million for research, and I'm sure Warren would love a small percentage of that ideally, but that the American Centre for Diseases Control have acknowledged the fact that she is a leader in the ME world, and so her research is kind of very relevant to the post-COVID syndrome, and so they've awarded her this grant. Anyway, moving on, I went to the IACFS conference this year, and you might think, oh, wasn't she lucky she went to America, but it was actually held online, a virtual conference which I've never been to before, and my daughter, who's also a GP in Rotorua, Sarah Dalziel, she came up and we sat there and went to it together, and ANZMES have paid for the registration fee and what have you, which was gratefully received. And it was 2 a.m. here in New Zealand, of course, because they were doing it, you know, in the middle of the day there in America. So we had to get up very early, but that was all right. We could sit there in our dressing gowns and slippers by a nice roaring log fire while they were all over there in their smart suits and what have you. But we didn't get the morning teas and things, which was a little bit disappointing. But anyway, it was a very good conference. It's just a one-day affair. Normally, the CFS conferences have been over about 5 days, but they had to sort of restrict it down, I think, because they didn't know how it was going to go. She sat there and we sat through it and made notes, and fortunately, because it was on Zoom, we were able to then go back into it again and look at some of it again. So between us, we wrote a report, which I can give this all to Heather afterwards, and you can look up and read the report online. But it was very interesting. I'll just pick out 1 or 2 points. The first, we sat there and we wrote our notes and we wrote it up, and as I say, Heather can give you the website link if you want to read up the whole conference. But there was the first segment was about COVID-19, because again, it was very relevant in America, and as you all know, the numbers in America are just escalating. So I won't go into that because you can read about it in the report if you want to. But there was a whole session on treatment then. There were a number of segments, but I picked out the ones that I thought you would be interested in. And the Japanese have done a lot of research over the years, and particularly way back, you know, in the 1980s, Kuritsune, who was the Japanese researcher who did a lot of brain scanning research and things, he set the trend off in Japan. And we don't hear a lot from them, but every now and again they pop up at a conference like this. And they've just reaffirmed really the importance that the more we understand the things that Erin has been talking about, that kind of thing is going to lead to treatment. And there is always this frustration that, you know, the patients with the illness do feel, why aren't we focusing more on treatment? Why has it got to be all this underlying science? And I think he just reaffirmed the fact that until we understand the science, treatment tends to be a bit hit and miss. Other ones I picked out was there was some talk about, okay, we haven't got a medication that works for this illness, but how about there are other approaches? And certainly there were 2 very powerful European presentations, one from I think it was Spain and the other one from Britain, both of which were showing that ongoing support, psychological well-being was really important to lift the level of illness, lift it to better feelings of well-being and so on. And particularly the one that I've mentioned there about visiting severe housebound patients, a lot of them did tremendously well, not necessarily well enough to get back to normal life and feel healthy, but a definite lift in their well-being by getting caring patients, people visiting them at home, doctors and nurses and psychologists and therapists and what have you, various sorts. So having kind of a go-between, someone that you could talk to, made a huge difference to the people who were severely ill. A lot of them were so very isolated. There was quite a lot of talk about low-dose naltrexone, and I will enlarge a little bit about that in a minute, but naltrexone is a drug used in high doses to treat people who are addicts and help them get off their drug of addiction, things like heroin and morphine and what have you. And the low dose, very, very tiny wee dose of naltrexone has been found to be of considerable benefit for up to 70% of people with chronic fatigue syndrome. And again, I'll enlarge a little bit on that in a minute. And then there was a really interesting presentation about POTS, which is the postural orthostatic intolerance, where people feel, they get up suddenly, feel really woozy and faint. And some people do actually pass out and they have to move very, very cautiously. And a very high percentage of people with CFS do have POTS. So looking at treatment strategies for that, and there are various medications tried, but this particular presentation showed that oral rehydration, as they called it, was really important, and we've tended to recommend that, you know, plenty of fluids, plenty of salt, but they found in this particular study that you needed a combination of salt and glucose, not just salt, and that the patients who had the salt and the glucose combination did much, much better than the patients who just had salt and maybe other fluids. So another good presentation.
Did they say how much of each?
Pardon?
Did they say how much of each?
Well, they were talking about sachets. Enolite, we get it as here, and you could have a sachet like 6 or 8 times a day. Okay. Now I'm trying to get this to move on. Oh, there we are. Then there was a lot of presentation about making diagnosis, a number of presentations about making a diagnosis. And Lucinda Bateman, who's an American physician in Utah, she she's got a very big clinic, the Bateman Horn Center, and there's a lot of talk, you know, people want to have a tilt table test. This is where you're lying down and they tilt you up very suddenly and they do all sorts of checks on your blood pressure and pulse and things, and it helps to make a firm diagnosis of what we call POTS or orthostatic intolerance or one of these kind of things. And she has found in her research that you don't actually need a tilt table, which is quite hard to get that test done. I mean, there's certainly a couple of cardiologists in Auckland who do it, but it's not something you can just trot off and get done at your local GP surgery, whereas this so-called low lean test, which has been started off originally by NASA to look at people who are travelling into space before and after and seeing whether some of these symptoms are a problem. And so they've devised this test so you don't need a tilt table, but you sort of lean up against a wall at a funny angle. It must be quite uncomfortable actually, but you spend about 10 minutes doing that, and they do all sorts of blood pressure and pulse measurements, I think 1 every minute while you're there doing this test, and then they get you to lie down and then another 10 minutes they do it. But you don't need the tilt table. This test has been shown to be just as reliable as tilt table testing. So it's a simple thing actually if your GP's got time he or she can do. So that was important. Again, I won't go into the next thing, which is the metabolic processes and changed amino acids, because Aaron has already talked a little bit Navio's work and the changes in the so-called metabolome, which is all the different chemicals in your bloodstream, of which, you know, a number. I mean, this particular person, he's replicated some of the research in Norway, found that 159 out of 660 of the chemicals were abnormal and different. Another study showed that if you put healthy muscle cells into ME serum, which is the sort of the colourless fluid that your blood cells all float in, there was a definite change in the way that the cells worked, and the mitochondria worked differently, and you got an accumulation of lactate, which is of what of course causes the crampy pains in your muscles if you're an athlete and you overdo it, or at the end of a, you know, maybe a long run or something like that. So lactate accumulation did occur in these particular cells. The UK have produced they should have had a conference in May, last May, 6 months ago now, and again my daughter Sarah and I were going to go to that. Very excited about the thought of it because they have it every year and it's a very, very good conference, but they couldn't have it obviously because of COVID, so they had to cancel it. But instead of which the ME Association over there have produced a really good brochure about the up-to-date research that's going on in Europe particularly. And again, there's a link there that you can get it downloaded. It's about 7 or 8 pages of, you know, reasonably readable, easygoing stuff because it's been produced by the British ME Association for members, not just for doctors and health professionals and researchers. So it's a nice, easy read, so even I could understand it, which a lot of the research stuff is way beyond me. You know, nowadays it's moved on to another level. So it's worth downloading that and having a little look at it. Some of the things that are occurring and being done there, again, I won't go into detail, but they have said, yes, of course, it is a multi-system illness. It affects, you know, everything from your brain, your heart to your kidneys. Some people muscles, it's very different. So some people have a predomination of neurological symptoms and some people have a lot of musculoskeletal symptoms. So we may be looking at a number of subcategories of this illness, not just one illness. And what they call comorbidities are common. So a lot of people have, in association with their CFS, they may have this POTS, the orthostatic intolerance. They may have problems with the brain function. You know, they may find that they have a lot of difficulty with concentration, so-called brain fog. There may be sleep difficulties. A lot of people do even get seizures. Endless possible things that seem to go hand in hand. Migraine, you know, there's a genetic tendency to have migraine and endometriosis, and these things seem much more common in patients with CFS. So, you know, a lot of understanding of some of the abnormalities maybe in the genes that are linked to this illness. And then, of course, you've got abnormalities in all these various symptoms, which, again, I won't go through, but if you look up online, any one of those conditions or scientific terms like metabolomics or microbiome or mitochondria, look up those things online if you've got access to a computer and relate it to CFS or ME, and you'll find there's a wealth of information now coming up. So that's all very exciting stuff. The Australian research, again, I'm only going to brush over it because I've talked about it before, but the team in Queensland are still looking very closely at the way that calcium moves in and out of cells, and I think you alluded to it a bit too. And that is considered very, very important, and they are making these explanations there of how and why it's happening. But the interesting thing really is the bottom line there, which says it's improved, the abnormalities are improved with this low-dose naltrexone, which we call LDN for short. And the low-dose naltrexone is being, you know, researched there fairly thoroughly and carefully, looking at what changes are occurring and why. The low-dose naltrexone is being looked at in various centres around the world because there are quoted about 70% of patients who do improve on it. The experience I've had is a little bit less than that. I think I could divide the patients I've had on it, and probably several hundred by now, into 3, and there will be one group who do really well and say, yes, this suits me and I feel good on it. There'll be another group who say, well, I didn't do much, maybe a little bit possibly, and a third group, another third, who will say, well, actually, I felt terrible on it. So, you know, you kind of, that's the way it is. So it's a little bit hit and miss, and it's often hard to pick out who's going to do well. But a lot of my patients want to try it because they've read in Facebook groups and things of people who've done well. And I think if they've got a genuine diagnosis of ME, chronic fatigue syndrome, and they haven't got any reason they shouldn't take it, and that may relate to other drugs that they happen to be on. So you've got to be a little bit careful, but it's often worth a try, and some people do seem to do really well on it, and it's thought that it quietens down some of the brain inflammation too that is very apparent in some of the brain scans they're now doing on patients with this. The so-called microglia, which are little white cells in your brain, are very much sparkling and on high alert, and LDN has been shown to quieten those down. So it's a useful option to be considering. I've then made a little list here, and again these things have come up either at conferences or things I've read of potential medication, because so many patients say, well, all this research, but why haven't we got the drug yet? And of course there isn't the drug yet, but these are some of the things that we use or are being researched. And again, I'm not going to go through it in a lot of detail as we'd be here for hours, but certainly hormones for some people are extremely helpful, particularly for women who are after menopause or going through menopause. Fludrocortisone is a drug that helps your body retain salt, and that's quite useful for those who've got this POTS, this woozy-headed feeling. Prednisone is an anti-inflammatory drug. I don't find it's generally very useful except in short courses, but it's something being researched. A lot of patients ask about. Then the psychological ones are things like antidepressants, Ritalin, which is a stimulant, and then anti-epileptics, which are used for pain control, gabapentin, pregabalin, and so on. Heart drugs, again, mainly for people with the POTS, the lightheadedness or a racy heart. It slows down the heart rate. And nimodipine is interesting. That improves brain blood flow. Very expensive drug, unfortunately, but I've had a number of patients who've tried it. Has to be got through a hospital pharmacy, and it costs, the one I've got recently, I think she told me it's about $150 a month. So, you know, these things are not cheap. We've mentioned the naltrexone. Again, that has to be paid for, and the cheapest that I've come across, you know, the cheapest source I've come across, let's say, is through the pharmaceutical compounding labs in Auckland. That one costs about $100 a month. Then you can use occasionally neurological drugs. There's some pyridostigmine, which is a drug used for a condition called myasthenia gravis, which is a neurological disease with a number of common features. So, you know, maybe some people with ME have got a borderline of that illness, or maybe the drug that we use for that illness has a borderline benefit in ME. Muscle relaxant is very handy for people who have a lot of muscle pain or who can't sleep because their muscles are tight, and particularly the Norflex is very good for muscle pain, and people often will take that at night. Some of these drugs are mildly addictive or habit-forming, so you do have to be a little bit careful, and they also interact a little bit with each other sometimes. So if you're on several things, you could be prone to sort of a build-up of lots of drugs, which we often call serotonin syndrome. The person gets too sedated and they almost could fall to the ground because they're on too many drugs all at once. Antivirals are used a bit if there's thought that a viral illness is still lurking, which in a few people it might well be. Certainly some of the herpes infections, and that would include things like shingles, keeps cropping up. And for those patients, going on to an antiviral over a long period of time can be quite useful and helpful. But Dan Peterson, who's the Incline Village person that you mentioned, he's a physician in the United States, still very active working in that area. And he has shown that spironolactone, which is a diuretic. It's a pill that gets rid of excess body fluid, actually has powerful antiviral properties. So that's quite useful and interesting, because antivirals sometimes do have some unpleasant side effects. And some people, the antivirals don't work, but he's found that some of his patients seem to do very well on that drug. So that's another interesting one. That's an ordinary prescription medication, so not a huge expense. And then the Norwegians, they did all this research in rituximab, which you've probably heard about over the last 5 years, 6 years or so. But unfortunately, even though they thought it might be a bit of a breakthrough for treating this illness, it didn't turn out to be. So they've moved away from rituximab, and they're now using, or doing some work, using another drug called cyclophosphamide, which is again a chemotherapeutic drug, and it's used to treat breast cancer. It's got some nasty side effects, but they are hopeful that the patients they are using it for do seem to be improving, and so they're doing proper, therapeutic trials now. And they're hopeful, and they may be right that this could be a drug that could be useful. Immune suppressants could be useful, because this is an illness for a lot of people where the immune system is very hyped up, certain aspects of the immune system anyway. And the one we have available here is called isoprenazine, and I've had a few people on it over the years, but we're talking $400 a month. So it's not something, again, that everyone can try. And the sad thing about that is it takes about 6 months to show whether it's working or not. So, you might spend all this money and get nothing out of it. But I have got a few patients who have been able to afford it, who have done well. So, you're kind of in a bit of a no-win situation sometimes with these things. An interesting one is the Suriname, which is no longer available, but may become available. It's used to treat sleeping sickness in Africa, or it used to be. And Ron Davis, who's one of the, again, lead researchers in America, probably heard of him, at Stanford University, and he has looked at sleeping sickness, which is obviously you fall asleep a lot, so there's a lot of common ground with CFS, and caused by the tsetse fly in Africa, and this drug was the original treatment for it, but it's been superseded now by other things. I'm not quite sure, so don't even ask me what their names are. But he has tried to get the manufacture of Suriname going again, because he felt the way that when you look at the chemistry of it, it could be very suitable for this illness. So even though there aren't obvious drugs quickly and readily available that have been proven to be useful, there's quite a range there of possibilities. And quite honestly, I have had patients who've probably been through the whole lot, and sometimes still waiting for the moment when they strike bingo. But I think, one weighs up the pros and cons of their symptoms and looks at what might be useful and helpful for that individual. But, you try one thing at a time. Some people come along and they say, I want to try this, this, and this, and this. And of course, some of these drugs would interact with each other. Some of them would be, not suitable for that particular patient anyway, because they've got other conditions or other drugs that they're on for other things. So it's not a matter of saying, let's try the whole lot. We sometimes say, okay, for Mrs. Brown, maybe Lowdose Naltrexone could be worth a try, or maybe for Mr. Smith, maybe mirtazapine or gabapentin or something. So we pick out the thing that might be useful for that person. But as yet, we haven't got sort of to the stage of this is the drug for ME, chronic fatigue syndrome. These are possibilities. We'll hope for the best that we move on. Nearly finished. Marianne Fletcher, who came to New Zealand with Nancy Klimas a few years ago, is a very well-known researcher in America. I'm working at the lab that's just got the $4 million, but unfortunately she's quite sick at the moment, so she's not working. not with COVID, she's got another illness. But she was the person who actually discovered the original test for glandular fever. So she's actually quite a famous person, though, you know, she's a very ordinary person and you'd never know, but it just came out in conversation with Nancy Climas, actually, who told me about it. Anyway, Marianne's research has carried on until probably about a year ago. She's now retired, but she's particularly interested in this substance called leptin, which is one of the many chemicals that's floating around our system. And she found that increased levels of leptin in the system did promote activity of the microglia in the brain, which are these sort of white cells that are on high alert, and they produce a lot of inflammatory chemicals and so on. So, and leptin seems to be activated all the time in people with ME/CFS, but it's also a chemical that's very much associated with your appetite and your eating and the risk of obesity. And when you are stressed, leptin levels go up. She found that decreasing the leptin in your system dramatically, and I imagine they use various drugs and things, caused you to be constantly hungry, which is not ideal, and also it increased your ability, or your inability to fight cancers. So you lost some of your immunity against cancers. So it was a matter of saying, okay, well, we don't want to get leptin levels right down, but we want to try and decrease them a little bit because this might help with some of the symptoms, such as the brain activity and so on. It's made by fat cells, so one of the things that people are recommended to do in the studies they're doing is certainly to try and decrease their weight carefully, not dramatically, but carefully. And that seemed to help a number of people. Now, you may find that anyway, losing weight if you've got ME/CFS is a benefit, because if you're carrying too much extra weight, it's like carrying a sack of coals on your back, so you're bound to be more tired. So getting some weight off is, apart from the leptin issues, likely to be beneficial, and also stress management, because stress increases leptin levels. So these are just simple things. Maybe weight loss isn't so simple, but you know, we'd all like to try and promote that idea. And also they are using this antiviral agent valganciclovir. That does also help reduce the microglial activity, and the microglial activity in the brain is considered one of the areas that creates a lot of the ME/CFS symptoms. So as well as being associated with the leptin, it may well be that there's a viral issue going on, because the work they've now done using that antiviral agent seems to be helpful. And of course, we've already said the LDN several times. So, you know, these things are happening. So I could look back on, well, I won't say I can look back on 72 years of research, but a good chunk of those years. And what's been achieved? Well, certainly the nomenclature, the way we name the illness has changed. So it started out, probably one of the earliest ones was Icelandic disease in 1948, I think. Iceland's a very small country, a population of about 500,000, I think, and they had a very severe flu-like illness in that particular year, and many people were struck down and remained ill for a very long time, and it became known as Icelandic disease. And then, of course, we had royal free disease, various American incline village, and they called it their own names, Tapanui flu, ME, so on and so on, chronic fatigue syndrome. They've called it, the Institute of Medicine called it SEID, which is another set of letters to looking at what's going on, something. And then there was the immune deficiency people, CFIDS, and many, many different names, but at least now it seems reasonably settled, ME/CFS. And people say to me, well, why do you have those two names? Why not one or the other? And I think it's a bit regional, because in Britain they call it ME, in Canada they call it ME, but in America they call it CFS. So, and various other countries, you know, use one or the other, and we tend to stick to the two at the moment. Then we've moved on. There was a lot of issues initially about the psychological theories, and is it all mass hysteria and what have you, but fortunately we've moved on to from there as we became very much more aware of the physical aspects of the illness, that this wasn't all in the mind. People did have a lot of very real physical symptoms which couldn't be attributed just to stress. And I think as time's gone on, of course, there have been more scientific studies, and as we've seen today from Erin, I mean, it's moved on enormously, looking at all these different approaches to research. There's been quite an emphasis too on what we call PEM, or post-exertional malaise, whereby it's very obvious that people with this illness do feel dreadful usually after pushing the exercise hard, whereas healthy people feel great after exercise usually, if they're healthy enough. So there's more sort of emphasis now on that aspect. Lots of treatments have been tried, as I've just outlined, and sometimes we're getting symptomatic relief. We're not getting cure of the illness, but we're getting relief of symptoms. And of course, all this very sophisticated lab work, which these sort of people are doing, beyond the abilities of people like me even to understand half of it, but it's shown that there are many, many abnormalities going on within the system, and I think that work is just going to escalate over time, and it's obviously an illness that involves every system in the body really, but gradually treatment is getting a little bit closer to something that might be the answer. And it's very likely over time that we're looking at, if we take the word CFS, it's a big umbrella term, and there are lots and lots of subcategories of it, as is evidenced by the fact that you get these different groups with different sets of abnormalities, different sets of symptoms, and so on. So, you know, everything's changing. Oops, I've gone the wrong way. And that's the end of it, isn't it?